This video will be a very important introduction to the block and will be focused on immunosuppressive therapies using organ transplants as our example indication for these agents. But keep in mind, as you encounter other indications for immunosuppression, like inflammatory bowel disease, for instance, that we talked about back in block 3, a good majority of these agents that we will talk about in this video and others in the block will be applicable as well. So when it comes to organ or allograft transplants, one of the primary goals of therapy is to prevent the body's immune system from recognizing the allograft as foreign and mounting an immune-mediated attack that would lead to allograft rejection. And there are several types of rejection that differ in terms of either time frame or the immune mediators that are involved. So we have hyperacute rejection that is almost immediate due to pre-existing antibodies that recognize the donor allograft as foreign. There is also acute rejection that typically occurs within weeks or several months after the transplant. And this can be cell-mediated, meaning that it is orchestrated primarily by T cells, leading to that rejection. Or it can be humoral, meaning that it is mediated by newly synthesized antibodies against the alloantigens, or the acute rejection can be a combination. And our last type of rejection we'll talk about is chronic rejection. And this occurs usually after the first year post-transplant or more, and is a combination of cellular and humoral mediated effects along with fibrosis. So we won't be discussing the mechanism behind hyperacute rejection in this video. But the simplified disease schematic we're going to go through today will be pretty applicable to both the acute and chronic rejection mechanisms, and what we are trying to avoid with induction maintenance therapy used in organ transplant. And the time frame for this process will be the biggest difference between the two. So we will start over here with our donor allograft cells, which may either include donor antigen presenting cells or APCs that interact directly with recipient T helper cells, which I'm showing you here as TH cells, or donor alloantigens can be taken up and processed by recipient antigen presenting cells to then present these antigens to those naive T helper cells. And this presentation of alloantigens, whether it be a true alloantigen or just a donor antigen presenting cell interacting with the T cell, regardless, these will trigger the activation and proliferation of T helper cells to TH0 cells. And interleukin 2 will play a key role in this process and promotion of T cell related events. So just as we discussed in the inflammatory bowel disease video in block 3, these TH0 cells will further differentiate based upon their cytokine environment. So for instance, TH0 cells will differentiate into TH1 cells via things like interferon gamma and interleukin 12. And then the TH1 cells then go on to mediate cell-mediated responses, like through the secretion of tumor necrosis factor alpha or TNF alpha, and more interferon gamma, which will recruit and activate macrophages to promote inflammation, or through the secretion of interleukin 2 again to promote the differentiation and proliferation of cytotoxic T cells, which I'm showing here as TC cells. TH0 cells can also differentiate into TH2 cells via things like interleukin 4, which will then go on to recruit and activate B cells, along with some co-stimulatory signals, leading to the production of alloantibodies and that humoral immune response. So this cascade leads to the formation of a slew of immune effectors that are primed to continue to recognize the allograft as foreign and mount the initial immune response as well as propagate the response, potentially leading to acute or chronic rejection depending upon the time frame. So moving to our next slide. Now, a number of agents targeting the immune system and these cellular populations are used to induce immune suppression prior to the transplant, maintain immunosuppression after the transplant to prevent rejection, and some of the agents we will discuss may be used for the treatment if rejection occurs. So keep this in mind and think about what each agent's place in therapy may be. So similar to the IBD video in Block 3, we will start off with agents working outside or on the surface of immune cells, and then work our way intracellularly, which means the first agents we will be discussing will be biologics. So the first agent we will be starting with will be basiliximab. Which, as you can probably guess by the name, it is a monoclonal antibody with its MAB ending, or MAB ending, and will be against an immunomodulating molecule because of the LI in the middle. And it is chimeric because of its XI in the middle as well. So basiliximab is a monoclonal antibody that is against the interleukin-2 receptor. So it acts as an antagonist here by binding this interleukin-2 receptor complex and preventing this interleukin-2 binding. And remember, interleukin-2 plays a key role in this promotion of T-cell related events, which plays a big role in rejection. So by inhibiting interleukin-2 binding to its receptor on T cells, interleukin-2 mediated activation is prevented and the response of the immune system to alloantigens is impaired. And this is why basiliximab is approved for the prevention of rejection as part of induction therapy regimens. The next agent we will discuss will be antithymocyte globulin. Or lymphocyte globulin, which are polyclonal antibody preparations that are made from purified preparations of immunoglobulins produced from either rabbit or horse serum that have been immunized with human T-cell lines. So the antibodies obtained target a variety of proteins on the surface of lymphocytes. While the exact mechanism of action by which these polyclonal antibody preparations exert their immunosuppressive effects is not fully understood, they have been shown to cause T-cell depletion following these T-cells being marked by these antibodies for clearance from the body. And as an added bonus for these indications, this agent may also interfere with the function of B cells, natural killer cells, and dendritic cells, depending upon which surface proteins are recognized by these preparations. So these antibody preparations play a role in both the prevention of rejection and the treatment of rejection because of its ability to quickly clear T cells from the body, preventing that key player from promoting rejection. However, because this is more of a cellular targeted therapy, it won't be super helpful for any humoral mediated rejection. And this brings me to the last agent that we're going to discuss on this slide, which is IVIG, or intravenous human immunoglobulin, which is essentially just pooled and purified IgG from pooled human plasma and provides a broad spectrum of neutralizing IgG antibodies and is usually used to provide passive immunity to those with immunodeficiencies. But in organ transplants, this is an option for organ rejection treatment because these pooled antibodies can essentially flood the immune system so that these alloantibodies recognizing the allograft antigens cannot find the respective cell to present that alloantigen to promote rejection and can function as an anti-idiotype antibody, essentially meaning that the antibodies from the IVIG can recognize the alloantibodies and bind them and tag them for clearance from the body as well. So based on these mechanisms, IVIG is going to be a potential treatment option for rejection when a humoral immune response is involved. So when it comes to important pharmacologic considerations, being aware of the general adverse drug reactions associated with monoclonal antibodies will also translate to these antibody preparations. So because they are proteins and huge molecules, there are a lot of opportunities for the body to recognize these different epitopes on the antibodies as foreign, leading to hypersensitivity reactions. Like anaphylaxis, and some need pre-medication before being administered. Also, some agents like the antithymocyte globulin can lead to cytokine release syndrome, which you might see abbreviated as CRS, which is an infusion reaction where the antibody actually triggers the inappropriate activation of immune cells and a surge of cytokines, which can be life-threatening, which is why a lot of these antibodies are infused slowly and the patient is closely monitored. And remember, because these agents target the immune system, there is a risk of lymphoproliferative disorders and malignancy, and infections will be listed as potential risks of therapy. So moving on to our next slide. So now that we have discussed the antibody-based agents used in the prevention or treatment of rejection, let's move inside the cell and discuss the remaining agents we will cover in this video. And hopefully several of these you will be familiar with, which we touched on in blocks 3 and 4. So moving to the next slide. So our first agents we will discuss and keep revisiting in this block are the corticosteroids, specifically the glucocorticoids. So these agents include things like prednisone, methylprednisone, dexamethasone, etc., and these are all potent anti-inflammatory agents. And these will bind the glucocorticoid receptor, which will then translocate to the nucleus to promote target genes. This will either inhibit the transcription of immune-promoting genes or promote the expression of genes leading to immunosuppressive effects. So the glucocorticoid-bound receptor can also recruit HDAC2 to modulate gene expression through the deacetylation of histones, causing pro-immunomodulatory gene repression. This will reduce lymphocyte number, activation, proliferation, migration, etc., to mitigate the immune system's normal function required to mount an immune response against the allograft that would lead to rejection. So while these agents are potent, remember that they come with a lot of concerns. So first, they are immunosuppressants, so there's going to be that risk of infection. But because they are steroids and they look like cortisol, they are also going to throw off a number of other steroid hormone feedback loops. So some of the major adverse drug reactions to be aware of are beyond infections. We're going to have the retention of salt and water, potentially leading to edema and hypertension, peptic ulcer disease, adrenal suppression. So the patient's going to need to be tapered off of these steroids, hyperglycemia, psychosis, Cushing's. There's also going to be a risk of cataracts and glaucoma, as well as osteoporosis and poor wound healing. So for all of these reasons, these agents are usually used to induce immunosuppression and to help treat rejection if it occurs, but usually the goal is to minimize the duration and dose of steroids the patient must take. And this is why you will see combinations of immunosuppressants with steroids initially, but when the patient transitions to a more long-term maintenance therapy, steroids will be minimized, like our patient in this week's case. So moving to the next slide, and this is going to bring us to our discussion of the steroid-sparing immunosuppressive agents, which we will break up into two groups, being the antimetabolites and the calcineurin-related inhibitors. And these are agents that would generally be started prior to transplant and then continued as long-term maintenance options to prevent rejection. So we will start with our antimetabolites, the first one being azathioprine, which you may see abbreviated as AZA, and we talked about this a little bit in the IBD video in Block 3. And AZA is a prodrug which is converted in the body to 6-MP or 6-mercaptopurine. And these agents look a lot like purine bases, so they are fed into the purine synthesis pathway, which we covered in the gout video. And this will act to inhibit a number of enzymes involved in that purine synthesis pathway, and they will competitively inhibit those enzymes. And one example is hypoxanthine phosphorybosyl transferase. So this will prevent that synthesis of new purines. This will deplete those purine nucleotide pools, inhibiting immune cell proliferation, leading to immunosuppression. So this agent was originally a chemotherapeutic, so its side effects are similar to that of chemos, where we are hitting those rapidly dividing cell lines. So bone marrow suppression, infections, GI toxicity. There's also going to be a risk of mutagenesis and carcinogenesis. And for this video, we don't have time to get into it, but azathioprine and 6-mercaptopurine actually have some really important drug interactions you should be aware of with allopurinol, as well as some pharmacogenetic considerations. So I would encourage you to look those up, but we won't get into them in this video. So our next antimetabolite that we haven't yet talked about in any previous videos is mycophenolate mofetil. And you'll commonly see this abbreviated as MMF. And mycophenolate mofetil is a prodrug that is metabolized to mycophenolic acid. And this is a potent and selective inhibitor of inosine monophosphate dehydrogenase, which, again, thinking back to the purine synthesis pathway from Block 3, this inhibition will lead to an inhibition of de novo guanosine nucleotide synthesis. So this will deplete those purine nucleotide pools, again inhibiting that immune cell proliferation, leading to immunosuppression. So because the similarities in their mechanism, mycophenolate mofetil is going to come with a lot of the same adverse effects as azathioprine. So moving to the next slide. So this brings us to our other group of steroid-sparing immunosuppressive agents that we're going to talk about today, being the calcineurin-related inhibitors. But first, we need to briefly go over one aspect of T cell receptor signaling. So when a T cell receptor recognizes an MHC antigen complex, this leads to activation signals through the activity of tyrosine kinases that will eventually activate phospholipase C, to eventually trigger elevations in intracellular calcium levels. Prolonged elevations in calcium allows for calcineurin to exert its phosphatase activity and dephosphorylate the nuclear factor of activated T cells, or NFAT or NFAT. And then once dephosphorylated, NFAT can then enter the nucleus to promote the transcription of genes promoting T cell differentiation and proliferation, like interleukin 2. The calcineurin inhibitors work to prevent this signaling and this transcription of interleukin 2, and other pro-T cell mediators by first binding the immunophilins, being either cyclophilin or FKBP, to form a complex that will bind and inhibit calcineurin so that it can not act as a phosphatase. So NFAT can never reach the nucleus to regulate gene expression, and this leads to downstream immunosuppression. So examples of calcineurin inhibitors would be cyclosporin and tacrolimus. So now the next agent is very similar to the first two, but works a bit later in this T cell activation cascade. So interleukin-2, as well as several others, are very important cytokines for promoting T cell activation and proliferation. So when interleukin-2, for example, binds its interleukin-2 receptor, downstream activation of the mammalian target of rapamycin, or mTOR, occurs, which is a key kinase involved in cell cycle progression and T cell proliferation. Well, sirolimus will bind the immunophilin FKBP and form a complex that will bind mTOR and inhibit its kinase activity, preventing its downstream effects. So as a bonus, the signaling cascade is also important for B cell proliferation, so this will have an effect on this additional immune cell population. So all three of these agents have a narrow therapeutic window, and they are metabolized by CYP3A4, and they can all be nephrotoxic. And they all come with the usual risks of prolonged immunosuppression, like this risk of cancer and infection. So monitoring for these agents is going to be really key. So moving to the next slide, which brings us to our summary slide for the immunosuppressants targeting intracellular components of immune cells, which today we mostly focus on our T cell populations. So moving to our last slide. So in summary, I hope this video has introduced you to a number of staple immunosuppressant agents that we will continue to revisit throughout the block for other indications, as well as a few specific agents that are used for organ transplants. And hopefully this video has highlighted a number of similarities across these different groups of agents, like mechanism of action or adverse drug reactions, that will be important themes you can use to help organize the different immunosuppressants and continue to become more and more comfortable with their pharmacology.